Hi, everybody. It's 6 p.m. in Paris, 6 p.m. in Badalona, 5 p.m. in London, 12 p.m. noon in New York. So, welcome everyone. Again, Happy New Year. I hope this year brings you all good health, success, and plenty of exciting opportunities. So this is the ICH, the International Academy for Clinical Hematology. And in 2025, we will continue this exciting journey of learning together, growing together, and collaborating all together. Today, we are very honored to have one of the leading experts in the field of MRD in ALL, namely Dr. Josep-Maria Ribera from Badalona, Spain. He is a consultant hematologist at the ICO in Badalona, but also he is the chief of the ALL study group within the Spanish cooperative PETEMA group. And we owe Dr. Ribera a lot because thanks to his studies and the studies from his group, our knowledge in this field has grown dramatically. And today, Dr. Ribera has kindly accepted to guide us through the complexities and advancement of monitoring minimal or measurable residual disease in acute lymphoblastic leukemia. I don't need to spend a lot of time convincing you that MRD has become a cornerstone in understanding treatment responses and refining personalized treatment strategies in ALL. So I think this session will explore the technologies, the clinical applications, and also the implications of MRD in improving patient outcome, especially at the era of T-cell engagers like blinatumomab. And the question is, of course, can we move away from chemotherapy? Can we move away from allotransplant? And of course, Dr. Ribera, his insight as a global authority are extremely important to all of us. So we all look forward to an engaging and informative session. So Jose, thank you for joining us, and let's get started, and we'll have some Q&A at the end.
Thank you, Mohammad, for this kind introduction, and thank you to the International Academy for Clinical Hematology for having invited me to deal about the still exciting topic of MRD in ALL. These are my disclosures. I will split my presentation for today in three topics. One is the MRD in pH positive ALL. The second is MRD in pH negative ALL. And the third is the MRD in T-ALL. Let's begin with Philadelphia positive acute lymphoblastic leukemia. So it's clear and it's well accepted for all of individuals dealing with pH positive ALL that the best point to achieve the prognostic value of MRD is not just after induction, but also just after consolidation. And 3 months is the best point to assess the prognostic value of MRD in this disease. This was initially seen or observed when we used the BCR-Abelson ratio by PCR as a tool for assessing MRD. And this is still considered the standard way of achieving the MRD level. But really, we do know it's clear that there are two subtypes pH positive ALL, according to the point of the hematopoietic development in which the leukemogenic event occurs. The typical lymphoid pure pH positive ALL is a B cell precursor ALL because the BCR-Abelson leukemogenic event occurs in a progenitor committed to the B lineage. But there is another subtype in which the leukemogenic event occurs in a multipotent progenitor, and this has an important issue for MRD assessment. It's clear that the prognosis of these subtypes of ALL under TKI-based therapies is the same, fortunately for us. But really, the measurement of MRD is different according to these subtypes. And an excellent study from the Graal group, the French Graal group, clearly demonstrated that IgTCR is better than the ratio, the ratio BCR-Abelson ratio for pH positive ALL. And when they developed this study in parallel, measuring in parallel MRD by these two methods, they showed that when MRD was assessed by IgTCR, this was an increasing value of MRD negativity, reaching almost 90% over the therapy. What occurred with BCR-Abelson measurement, this was a low level of MRD negativity. And this was attributed by BCR-Abelson ratio were considered as leukemic cells, non-lymphoid cells, myeloid cells that show also the BCR-Abelson feature. So, and for that reason, when they compared the disease-free survival according to the methods of measurement, they clearly showed that when IgTCR was less than 1 to 10 to minus 4, the outcome was the same irrespective of the BCR-Abelson MRD was positive or negative. And when they assessed the prognostic impact according to method of MRD detection, they showed that when used BCR-Abelson method, there was no prognostic impact of MRD at any time point. And contrary, when they used the IgTCR MRD in the same samples, it was a clear effect of negative MRD in the prognosis. It's not an early time point, as we know, but also in intermediate or late time points, even before allogeneic stem cell transplantation. Thus, although many groups still measure MRD by BCR-Abelson, others do this by the two methods in parallel. But really, I think in the forthcoming studies, the preferred marker for MRD in pH positive ALL will be the PCR of IgTCR rearrangement. And what occurs of allogeneic stem cell transplantation when MRD was measured by ICTCR? Really, what occurred that those patients with a standard risk pH positive ALL defined as less than 10 to minus 4 MRD level after cycle 2, and white blood cell count less than 30 30,000, really those patients have the same outcome if were transplanted or non-transplanted. And transplantation had only favorable impact for the high-risk patients, defined as low MRD, but MRD positivity after cycle 2 and white blood cell count over 30,000 per microliter. So really could help us to split the patients who will need transplantation or in Ph positive ALL. Now, but we are now facing in the ponatinib era, and ponatinib really has been evaluated in clinical trials, phase 2, and even in phase 3 trial, in which ponatinib was compared with imatinib and attenuated chemotherapy. And what was demonstrated is that the MRD negativity after cycle 1 of induction was significantly higher with ponatinib versus imatinib. And this was translated in a prolonged, more prolonged progression-free survival in the ponatinib arm, and a trend, not significant trend, for a better event-free survival in patients who received ponatinib upfront. Based on this data, ponatinib has been approved in US for as first TKI therapy in any case of Ph positive ALL. But now there is a step ahead, and really now there are phase 2 trials combining blinatumomab and ponatinib in patients with newly diagnosed Ph positive ALL. And when we see the MRD after one cycle, the MRD negativity was about 60%. Almost the double that was reached with ponatinib and chemotherapy. And after several cycles, several consolidation cycles, the MRD, the deep MRD negativity reached almost 95%. Really, this is very important. So the combination of a potent TKI with immunotherapy allows a deep clearance of MRD, and really it was associated with a prolonged overall survival and event-free survival. And when this was analyzed for prognostic factors, the most predictive factor for relapse was white blood cell count over 70,000, and negative MRD at early time point did not have predictive value for relapse. So really is very important to know that in the era of ponatinib and blinatumomab without chemotherapy, the outcome is really exceptionally good, and the most important predictive factor was not MRD, because it was universally negative at any time point. And the only prognostic factor was, again, our old blood cell count. Let's see what occurs in Ph negative ALL. The situation is different because the most important time point for MRD is early time point, just after induction. And in our study from the PETEMA group, we clearly demonstrated that an early MRD negativity achievement assessed by next generation flow cytometry with a sensitivity to 10 to minus 6 the post-induction MRD level was associated with a very good outcome. These were patients, adult patients with high-risk features ALL, and really any of these patients was transplanted. So this indicated that early MRD negative achievement using a highly sensitive method is associated with a very good prognosis. And the prognosis is even very good if this MRD level, that 1 to 10 to minus 4, was achieved by mid-induction, just at day 14 of the induction therapy. In US, the most popular way to assessing MRD is NGS. NGS reaches a sensitivity 1 to 10 to minus 6, and the NGS tool has been validated by FDA. So all Americans use NGS to determine the MRD. So in the MD Anderson cancer experience, those patients with early negative MRD by AGS either have a standard risk or high risk ALL had a perfect good prognosis. And those patients who, on the contrary, those patients who have NGS MRD positivity and high risk ALL have a poor prognosis, and those patients were clearly candidates to allogeneic stem cell transplantation, contrary to the patients who achieved a very good early negative level of MRD assessed with a high sensitivity method, in whom the prognosis is really very, very good. Well, when compared a standard flow cytometry, a standard, so the sensitivity is low, 1 to 10 to minus 4, versus ultrasensitive NGS, 1 to 10 to minus 6, the cumulative, this is experience of again, from the MD Anderson, those patients who have an MRD negativity by NGS at the time of complete response, any of these patients relapsed. And contrary, those patients who have MRD positive by NGS, the probability of relapse was about 40%. And when those patients when this comparison was performed, those patients who were MRD negative by flow cytometry and NGS, any of the patient relapses, but those patients who were no difference, and those patients who were MRD positive by NGS, and according the level of MRD by standard flow cytometry. So another issue is, should peripheral blood replace the bone marrow in patients for MRD achievement? An interesting study, again from US, using NGS-based MRD assessment after transplantation on after CART in parallel samples, in pirate samples, really demonstrated a good correlation of blood versus bone marrow for MRD assessment. This has evident clinical implications, because it's easy to detect, easy for the patient especially, to detect MRD in peripheral blood, and it's not easy for the patient to have a repeated bone marrow samples for MRD assessment. But when in the Spanish PETEMA group, in our current trial, when we compared for B-cell precursor ALL, the bone marrow and peripheral blood, this correlation was not good, and really there was a 24% of discrepancies in the MRD level in peripheral blood and bone marrow. Other groups have also shown, even by IGTCR NGS assessment, that there was not pretty good correlation between bone marrow and peripheral blood for B-cell precursor ALL. We will see later what occurs in T-ALL. But really, still there is not a trend for physicians to avoid bone marrow assessment for B-cell precursor ALL and substitute by a peripheral blood assessment. So what it's clear that MRD status is not only a predictive for overall predictive of overall survival and disease-free survival, but the MRD status before and after allogeneic stem cell transplantation predicts relapse-free survival and overall survival. And when this is undetectable, really that is achieved by NGS 1 to 10 to minus 6, the probability of relapse after transplantation is really good, but it's not zero. So the predictive value of MRD, even very low level, is still not perfect, but it reaches, it's going to the perfection. Okay. Well, and this has important consequences, because the question is really, do we need to transplant patients who are persistently MRD negative after induction and consolidation? And really, there are several phase 2 studies indicate that this could be the case, that transplantation could be avoided in patients who achieve MRD negativity after induction and consolidation. But we need a randomized trial, and in the last TASH trial, the German group presented the results of the only randomized trial that faces the chemotherapy versus allotransplantation in Ph-negative ALL with high-risk feature and MRD negative patients situation after consolidation. And what occurred is that for B-cell precursor ALL, there were no significant differences in the transplanted and non-transplanted patients for overall survival, a trend of less remission duration in non-transplanted patients, and on the contrary, for TALL, high-risk TALL, those patients who received chemotherapy had a significant better survival than those patients who were submitted to allogeneic stem cell transplantation. And when it was by intention to treat, but when the analysis was done as treated patients, again, for high-risk B-lineage ALL, absolutely no differences were observed in transplanted versus non-transplanted patients, in patients who were MRD negative after consolidation. Perhaps there is one exception for IGTCR assessment as MRD tool in Ph-negative ALL, and this is the KM2R rearranged ALL. Again, the French group demonstrated that those patients that were in whom PCR was assessed by the KMT2A fusion showed better outcome, better discriminating outcome than those who were in MRD was achieved by IGTCR. Let's see, those patients who have negative status by the two methods, there is no problem, less cumulative incidence of relapse, good overall survival in spite of being KMT2R rearranged ALL, but those patients who have KMT2A rearrangement positive have the same probability of relapse if they were IG TCR positive or negative. So really, for the French group, the method, the ideal methods for assessment of MRD in patients with KMT2 a rearranged ALL, it was the PCR for the fusion, not for the IgTCR. Well, there is MRD is perhaps not the only tool. The most important, yes, but not the only tool for assessing the prognosis in B-cell precursor ALL. And an elegant trial in pediatrics, in UK, they demonstrated that for a definite level of MRD, for example, 1 to 10 to -4, the relapse probability was different according to the different genetic subtypes of ALL. And we demonstrated the same in our current study in adult ALL. Patients with good prognostic genetic subgroups, for example, PAX5P, ATR, high hyperdiploid, T119, achieved a very good level of MRD negativity after induction. And contrary, PH-like ALL, KMT2R ALL, low hypodiploid ALL achieved a poor MRD negative status. When we used a more stringent cutoff, really it was even more evident those patients with good genetic or a standard genetic subtype had very low, high level of MRD negativity than those who had a high risk genetic subtype. Well, and this has also prognostic implications. And in our current trial, those patients who have combined MRD level less than 1 to 10 to -4 at the end of induction and standard risk genetics really had a very good outcome, more than 80% survival, and contrary, those patients who have MRD positivity and poor high-risk genetics have the poorest outcome, and the other combinations have an intermediate outcome. And this was clearly related for cumulative incidence of relapse. Really, those patients who had the most good combination, MRD, low-level MRD, and standard risk genetics, the relapse probability was less than 20%. Well, we are now in Ph negative ALL, we are now in the immunotherapy era. And for example, in this phase 2 trial conducted by the GMEMA group, they evaluated the MRD level when blinatumomab was added in consolidation in newly diagnosed patients with B-cell precursor ALL, and demonstrated that just one dose of blinatumomab intercalated during consolidation elevated the MRD negativity level from 70% to 93%, and this has prognostic significance. So really, we are facing an interesting situation now, because when we use a cutoff of MRD less or 1 to 10 to -4, when we added blinatumomab to the chemotherapy, almost all patients will achieve an MRD negative status at this cutoff level. So this will imply that we will need more sensitivity methods for MRD assessment and really next generation flow or next generation IgTCR will really be needed in order to assess the impact of MRD in the prognosis when we use immunotherapy in frontline. Really, when patients achieve an MRD negative status less than 1 to 10 to minus 4 after consolidation, those patients who receive blinatumomab combined with chemotherapy had a very significantly better overall survival than those patients who received consolidation chemotherapy only. And this phase 3 trial, the famous Icoca-Green E19 trial, recently published in New England Journal, led to the FDA to approve the use of blinatumomab in consolidation in patients with MRD negative status. So, but when we analyze in depth this study, we have the authors demonstrated that the advantage of blina versus standard of care was restricted to patients, young adults, patients younger than 55 years, and this was not evident in patients with older than 55 years. So we have to take this into account in order to uh, um, show the effect of blinatumomab in consolidation in patients with MRD negative status. This you know that this is submitted also. The use of blinatumomab in this situation is now currently submitted to EMA in order to approve or not the use of blinatumomab in consolidation for adult patients with MRD negative ALL. Well, but the impact of NGS negative MRD on outcome not only is restricted to chemotherapy, transplantation, immunotherapy, it's also seen after CAR T therapy, and at 1 month after CAR T, and especially after 3 months of CAR T, it was an effect of MRD negativity, deep MRD negativity on the outcome. This is true by T-cell and also has been recently demonstrated in adults with OBE-cell. So really, those patients who achieve a deep and early MRD negative status after CAR T show a better prognosis than those patients who did not achieve this early deep level of MRD. What about TALL? Well, in general, we can see that MRD has also the same prognostic impact as in BALL, but really there is an increasing consensus that in TALL the assessment in peripheral blood or in bone marrow show equivalent results, and this is very important for our patients. And several studies, I show the study from our PETEMA group, but other studies demonstrate that almost perfect concordance between the level of MRD in bone marrow and peripheral blood. And this is a good news for our patients. Really, the level of MRD is different according to immunologic subtypes of TALL. For example, patients with early T-cell precursor ALL show a high level of end induction MRD, and those patients with near ATP also have a very high level of MRD positivity, higher than the remaining subtypes of TALL, thymic or mature TALL. And this is correlated with the event-free survival and overall survival. This study was done in children, but we have seen this also in adults. ETP ALL is the poorest subtype of ALL because those patients with ETP ALL, most of them shows a high level of MRD positivity at end induction. And again, genetics matters in TALL. And again, the French group have demonstrated that the combination of end of induction MRD and NGS subgroups defined genetic subgroups of TALL defined by NGS and extreme hyperleukocytosis, these three parameters allow to classify the TALL patients according to three subgroups: a favorable subgroup showing at end of induction MRD less than 1 to 10 to minus 4, a standard genetic risk assessed by NGS, and low level, no extreme hyperleukocytosis. And they have an excellent prognosis. And the prognosis was less excellent in patients who have the high risk genetics and hyperleukocytosis or end-induction MRD positivity. So again, similar that occurs in ALL, MRD matters, but also the genetic background of the disease matters. And this, and as occurs in B-cell or ALL, the trials with CAR-T for relapsed refractory TALL, in this case the CD7 CAR-T from China, demonstrates that there is a high level of MRD negativity in bone marrow after the CAR-T, and this has a translation in very good survival, although more than half of the patients received a subsequent allogeneic stem cell transplantation. But really, what is clear with this trial and other phase 2 trials running currently, that a deep MRD negativity in relapsed refractory TALL treated with several CAR constructs is high and is probably associated with a very good outcome. So to conclude, there is extreme importance of using high sensitivity tools for MRD assessment, especially in the immunotherapy era. And perhaps next generation flow and next generation sequencing are the tools that we will use in the near future. For pH negative ALL, very low level of MRD at the end of induction and at an early time point is associated with excellent prognosis and no need for transplantation. This is an important issue. The immunotherapy improve outcome even in patients with MRD negative status. So the association of immunotherapy we know that in MRD positive patients improve the prognosis, but the most important thing that this occurs also in MRD negative patients. The high levels of MRD negativity after CAR-T are associated with improved outcome, and we cannot forget the genetic background, because the MRD level is not the same according to the genetic background. For pH positive ALL, it seems quite clear that IgTCR will be a better method than the traditional BCR-Abelson ratio. The ponatinib upfront improved the MRD negativity compared with imatinib after induction, of course, and later on. And the combination of ponatinib and blinatumomab shows a high frequency of MRD negativity status and improved outcome without the need of chemotherapy or the need of very low need of chemotherapy, for example, such as steroids. And for TALL, there is an excellent concordance of the levels in bone marrow and peripheral blood, and also the genetic background matters, and even the white blood cell count. And that's all. Thank you very much for your attention, and I'll be glad to try to answer the questions from the panel. Thank you.
Thank you very much, Jose, for really beautiful talk. I think you managed in less than 40 minutes to give us an overview of a journey which has been ongoing now for more than 30 years. So really, thank you very much. So we have a few questions. Let's take 5 minutes for these questions. And one question is about the technique and the threshold. In routine practice, in your practice today, what is your preferred technique and what is the threshold? And we have another question. What are the key time points when one should perform MRD evaluation for ALL?
In Spain we have a broad experience with flow cytometry, and we have implemented the next generation flow cytometry that offers a sensitivity of 2 to 10 to minus 6. Quite similar to the next generation sequencing. This allows us to assess the MRD in a centralized way, and having a rapid answer to the centers who for deciding what to do of the patient. It seems it has these advantages. Well, this is the time points. The time points is clear for pH negative ALL after induction and after consolidation. It's clear. After consolidation means or before transplantation for patients who we decide to transplant. And for pH positive ALL, we screen after induction, but we do not take decisions at that time point. And after consolidation, it is 3 months is the decisory time point. We still, in this case, we still are using the BCR Ivelson. We are also classics. We have not moved to PCR, IG, TCR, PCR. But I think that we will move in the near future because the evidence is increasing and increasing in this way.
So in line with this question, we have another question from Dr. Alexandra Gior about how would you assess MRD in a patient with T lymphoblastic lymphoma, but also a mediastinal involvement?
Wow. Wow, a difficult question, no? In sometimes there is in lymphoblastic lymphoma without morphologic bone marrow involvement, there is an occult bone marrow involvement, and we detect this by next generation flow. If this occurs, this will be the way that will follow the disease. The problem is in patients that we do not find bone marrow involvement either morphologically or at MRD level. In that time, we use morphology imaging. So there is no other way in our setting. No, we do not use systematically NGS for several genes no, we do not use systematically. So we will use a PET CT scan.
Okay.
But there is no other method. This
Thank
is
you
not
very
good,
much.
but this is the only we have.
So we have another question. At the same threshold, can we consider that all MRDs are equal?
No, really no. It depends on the genetic background. So MRD for example, less than 1 to 10 to minus 4 in a patient with hyperdeployed ALL, it's very good. It has very good prognosis, and this level for a patient with KMT2R ALL has not the same prognostic. For example, and specifically for KMT2R ALL, we have observed that even those patients who have a good MRD status after induction, they have an early relapse. And some patients cannot be transplanted because they relapse before. So, and they have a good MRD, a pretty good MRD level, but they relapse. So I think that genetic backgrounds counts and counts a lot.
So that brings me to another question from the audience, whether uh, does this mean that MRD negativity cannot overcome the genetic background, the biology of the disease?
I think that not completely. I think that there is a partial overlap. Those patients with good genetic background have a good MRD negativity. So yes, but there is not a perfect correlation. Patients with good MRD clearance and poor genetic subgroups have a high probability of relapse, not anticipated by the MRD negativity status.
Okay, excellent. Thank you very much. Let's take one last question, and this is about how frequently would you monitor MRD during the observation or maintenance phase?
Yeah, it depends if the patient is included in a clinical study or it's doing by the physician
Standard
discretion.
of care, yeah.
But in a clinical trial, we will do is mandatory after induction, after consolidation, before transplantation in the patients who are transplanted, and in the patients who are not transplanted is every 3 months during the first year, the second year every 4 months, the third year every 6 months. So it depends on the resources or in other situations. And after transplantation, this is we do the same. At any moment that we have an assessment of MRD, a assessment of response in bone marrow, we do an MRD. But really, in the first year, every 3 months, sure.
Wonderful. Thank you, Jose. I think we will stop here the Q&A. I'm sure colleagues can reach out to you for specific questions. So I'd like to thank you all for joining us today for this very, very exciting, insightful webinar on MRD in acute lymphoblastic leukemia. I hope this session has provided some valuable knowledge and a deeper understanding of the critical role of MRD in advancing personalized treatment strategies and improving, of course, survival and cure. Very, very special, warm thank you to our top expert speaker, Dr. Josep-Maria Ribera, for sharing his expertise and his perspective. And again, as I said in my introduction, let's continue to collaborate, to innovate, and translate all of these novel findings into better care for our patients and for patients worldwide. Thank you, and we look forward to seeing you at future events by the International Academy for Clinical Hematology. Thank you, and take care.
Thank you again, and it's my pleasure to collaborate from now and on for future events. Thank you very much.
Thank you.